Hello, this is Kim Jong-il. We are going to cover the topic anchorage. Anchorage means a place where a boat can be anchored. In orthodontics, anchorage means the reactive reaction when we move teeth. We should consider the reaction while treating. There are some cases that show crowding in the anterior region, labially inclined incisors or normal angulated incisors. There are four types of anchorage. The extraction space is about 7.5 millimeters. If we divide the space into posterior and anterior regions, the case where the posterior teeth move about 3/4 forward is called minimum anchorage, and the case where the anterior teeth move about 34 back into the extraction space is called maximum anchorage. If the teeth move a half amount of the space, it is called moderate anchorage. Moderate anchorage means that when closing the space, the anterior region moves a half amount and the posterior region moves the other half. There is another anchorage called absolute anchorage, which only anterior teeth close the space without posterior movement. In this case, we should consider crowding, incisor inclination, and expected tooth pattern during the finishing stage in the anchorage. In some cases, we should solve this discrepancy. If the space is less than 4 millimeters, discrepancy can be solved with the third molar extraction. If the space is greater than 15 millimeters, which means maximum anchorage, discrepancy can be solved by moving the anterior teeth backwards after the first premolar extraction. What would happen in moderate anchorage and minimum anchorage? After the extraction, there would be extraction space left. In the case of incisor inclination, we should check anchorage considering the crowding in the anterior region, but also inclination in the anterior region. Whenever the anterior teeth move 2.5 degrees backwards, incisors are retracted 1 millimeter. When we divide the case into minimum anchorage, moderate anchorage, maximum anchorage, in the case of maximum anchorage, incisors are retracted in 5.6 millimeters of space. 14 degrees of change is needed. U1 to FH is 114 degrees, normal. If U1 to FH is higher than 128 degrees and IMPA is higher than 104 degrees, maximum anchorage is needed. Of course, in the absolute anchorage, if we use mini screws, we have to close most of the extraction space. If angular change is 18.8, U1 to FH is higher than 133, and IMPA is higher than 109, we can use mini screws. If the U1 to FH is higher than 123 and IMPA is higher than 99, it becomes moderate anchorage. Let's take a look at this patient. Case A has protruded lips. U1 to FH is 132 and IMPA is 104. What do we do? Absolute anchorage can be applied in the maxilla, and maximum anchorage can be applied in the mandible. What about case B? U1 to FH is 121, so minimum anchorage or moderate anchorage can be applied. If U1 to FH is 102, moderate anchorage or maximum anchorage can be applied. In case C, U1 to FH is 126, so maximum anchorage can be applied and it should change into moderate anchorage in the end. If IMPA is 104, maximum anchorage should be applied. In this case, the tooth movement in the finishing stage can be changed by the state of the tooth movement. The more force is applied to the upper incisors in Class 2, and the more force is applied to the lower incisors in Class 3. Class 2 has dentoalveolar compensation, The upper incisors are lingually inclined and the lower incisors are more labially inclined. If maximum anchorage is applied when the upper incisors are lingually inclined, it is more likely to be worse. In Class 3, the upper incisors are labially inclined and the lower incisors are lingually inclined. If the lower first premolar is extracted in the Class 3, the lower incisors would be lingually inclined during the space closure, and it will be more lingually inclined while finishing. This is the case that the patient has severe anterior crowding. Profile view is not bad. In this case, after aligning, the treatment becomes easier by extracting the first premolar and aligning. If a patient has protruded lips with slight crowding, you should examine carefully. U1 to FH is 114, normal. It is maximum anchorage and the anterior teeth move backwards by 7.5 millimeters. Then, U1 to FH should become 132.8 degrees. 90 of IMPA is normal. So if IMPA is a 108.8 or higher, the anterior teeth would move without moving molar forward. This is a 13-year-old girl. Anterior open bite and lip protrusion are observed. It's not bad from the profile view, however, she cannot close her mouth. There is greater mentalis muscle activity. ODI is 63, APDI is 91, and CF is 154. It is Class 3 high angle. FMA is 37, UOP is 13, and POP is 13. However, U1 to FH is 121 degrees. The teeth are labially inclined. IMPA is 93 and IIA is 108. She has protruded lips. I used to extract the third molar only due to the severe lingual inclination of the lower incisor after premolar extraction. What would happen if the only third molar extraction is made? It would be hard to change the profile. Even though the lower third molar extraction is made, there would not be enough space where the lower second molar moves backwards. It means that anterior open bite would be prone to recurrence in the future. Furthermore, in the past, the upper second premolar and lower first premolar extraction was made because it is Class 3. What problems would happen? The lower incisors are likely to be lingually inclined, and it is hard to close the space as well. There would be a high chance that the space become open. Let's check the angle. U1 to FH is 121 for this patient. Normal range is 114, so 7.2 degrees of change is needed. There is no upper anterior crowding. In this case, it would become aesthetic if the upper incisors are retracted by 2.8 millimeters to make 7.2 degrees change. In other words, the upper incisors should move backwards by 2.8 millimeters, and teeth number 5 and no 0.6 move forward by 4.7 millimeters. If there is crowding, it would be easier by resolving crowding. However, this patient doesn't have crowding. On the other hand, let's look at the case of extracting the upper second premolar. Then for this patient, 2.8 millimeters should move backwards, and tooth number 6 move forward by the remaining amount. Would it be better to extract the upper first premolar or the upper second premolar? It would be better to extract the second premolar. So if there is discrepancy, especially if there is moderate or minimum anchorage, it is necessary for the posterior teeth to move forward to solve discrepancy. So, even though the mouth is protruded, you should move backwards as much as you can and then change the treatment if you think it's not aesthetic. Or you need to extract based on the anchorage from the beginning of the treatment. The anchorage is the resistance to movement. Basically, it is closely related to the root surface area, which means that it is also closely related to PDL periodontal ligament area. In other words, as the root is bigger, the anchorage value becomes also bigger because the contact area becomes bigger. Dr. Profit announced the anchorage value and root surface on the first molar, the second premolar, anterior teeth of upper and lower like this. In the case of upper teeth number 5 and 6 and teeth number 1, 2, and 3, it would be 6 versus 4. The ratio would change if the upper canine moved backwards. The root surface area on the lower teeth number 5 and 6 and teeth number 1, 2, and 3 would be different. In addition, Jerabak considered the lower incisor as value of 1 and the lower first molar as value of 10, and gave a value to anchorage. And he said that we have to choose anchorage according to various extraction options. It's protruded like this. You should consider how to close the space after looking into it. If protruded, many try to move them backwards by enhancing the anchorage. So the first option is extending the appliance to the upper second molar. Then, TPA, lingual arch, and headgear is available. In the first case, if the appliance is extended to the upper second molar, the root surface area unit A is bigger and unit B, so it is less likely for the posterior teeth to incline forward. In Mia, move the upper canine first. In the case when the upper canine moves backward, the anterior region moves by 60% and the posterior region moves 40% to close the space. In the case of the lower, the anterior region moves by 70%, or number 5 and 6 move by about 30%. If the appliance is extended to number 7, the anterior teeth usually move by 80%, the posterior teeth move by 20%, or the upper posterior teeth move by 70%, the posterior teeth move by 30%. In the case of extracting the lower premolars and extending the appliance to the tooth number 7, the lower anterior teeth move by 8.2 of extraction space, or the posterior teeth move by 1.9 of extraction space. At this point, understanding of the factors affecting anchorage value is needed. First, bone density of maxilla and mandible. Second, whether the teeth are mesially inclined or uprighted. Third, tooth movement pattern. The maxillary bone has different cortical bone compared to the bone in the mandible. In the case of the mandible, when closing the space, it's hard to move teeth because the cortical bone is thick. On the other hand, the bone in the maxilla has cancellous bone, so it's easy to move teeth. What you need to consider is whether the posterior teeth are mesially inclined or uprighted. In the case that the teeth are mesially inclined, if we close the space, the posterior teeth are more likely to be mesially inclined. On the other hand, in the case that the teeth are uprighted, when closing the space, it is less likely for the posterior teeth to be mesially inclined. In Mia, we should check the mesial angulation of each tooth based on POP and curve of Spee. Next, understanding of the teeth movement pattern is needed. In the case of Class 2 elastics, during the space closure, the anterior teeth move a lot and the posterior teeth move slightly forward. In the case of Class 1 and 2, when finishing, the Class 2 elastic force are applied. What is the Class 2 elastic force? It means that the upper entire dentitions move backwards and the lower anterior teeth move forward. Which areas are applied the same force to overlap? It would be the upper anterior teeth. If you can control the upper anterior teeth, it's easier for orthodontic treatment. What about Class 3? While finishing after space closure, the force is applied to the lower anterior area. So before finishing, it is important to prevent the lower incisors from lingually inclining too much. If there is discrepancy, we can divide maximum anchorage, moderate anchorage, and minimum anchorage situations. In the extraction case, the premolar's extraction is necessary. If the premolar is extracted, the discrepancy is solved in the maximum anchorage case. However, there would be remaining space in minimum anchorage and moderate anchorage. So, while closing the space, you need to find another way rather than moving the anterior teeth. The treatment moving the molars forward is needed. Then, you can close the space maintaining aesthetics. Thank you for watching.